Dễ thương vậy. Cũng nhiều á.
Nhiều lắm. Rồi đi nặng mấy lần cũng đỡ đỡ chứ hổm thường thấy ghê hơn nữa. Bự bự xong rồi. Nó để mẹ đi học về mẹ lấy cho con vậy thôi. Hồi trước nó cho nặng, giờ nó không cho nặng nữa, nó nặng hơn mặt nó. Đau không đi?
Không.
Quen rồi đau thử rồi. Mẹ nặng mấy một đau.
Lát nữa em gửi cho coi. Lát nữa làm xong á, gửi cho coi. Rồi từ từ thưởng thức.
Về để anh coi.
Coi chất lượng của cái mụn đây như thế nào ha.
Không chịu đi nữa đó. Nói ở trên đây, nói trên đây lấy ngon rồi rẻ nữa, ở dưới mình lấy mắt mình hết ra nữa. Nói thì rẻ mà đi gì mắc không hết tôi rẻ đi hết. Mặt mày hay có tí màu xinh xinh nữa, ở đây mình tiếp nha.
Đúng rồi đó.
Bên hàm với chán nhiều.
Lấy cục nào xứng đáng cục nấy. Hai mẹ con đi từ đó qua đây là hết bao nhiêu phút vậy?
45 phút.
Mấy này là cho coi trực tiếp luôn.
Trời ơi, đưa lên cái này một đồng nó cái đá luôn. Bây giờ mặt. Nuốt không đi?
Nuốt.
Nhiều quá trời nè.
Bà luôn. Tính cuối tuần mới đi. Em ơi, còn bữa nào nghỉ bữa nữa đi bạn nữa.
Không, bên em nghỉ lễ 3 ngày mà. 3 ngày chứ.
Nó đi học nè.
Học lớp 11 hả em?
Yeah.
Rồi mút tiền kia ta đưa đi nữa. Này phải đi mấy lần á.
Cô cái gì cũng nhiều á.
Nhiều á. Rồi, nào làm nước đi chị nha. Chứ mặt nó đợi một tiếng còn chưa đặng hết nữa. Cô cái chán đã. Chán ẩn đó chị ẩn.
Như sao đây? Nhiều lắm em ạ. Trên mài nó cũng khó em ơi. Chân mài nè, dọc cái chân mài quá trời mụn luôn. Cơm chưa Thư? Okay.
Same evening will cause severe irritation. Once your skin is adapted to retinoids alone, typically after 8 to 12 weeks, you might carefully introduce another active on different evenings. Eventually, some people successfully combine retinoids with other treatments, but build up to this gradually. Vitamin C and other antioxidants can be used with retinoids. Apply vitamin C in the morning and retinoids at night, or apply them on different days. Niacinamide can be used with retinoids in most cases, but some people find them together irritating initially. SPF 30+ broad-spectrum sunscreen is absolutely mandatory every single day when using retinoids, even if you don't plan to go outside. Window glass blocks most UVB rays but not UVA rays, meaning significant sun damage can occur even indoors. Reapply sunscreen every 2 hours if you'll be in the sun. Wear protective clothing, hats, and sunglasses when possible. The combination of retinoid use and sun exposure can cause severe reactions and permanent skin damage. As your skin adapts to retinoids over 8 to 12 weeks, gradually increase usage frequency. After tolerating 2 to 3 times weekly for 4 weeks, increase to 3 to 4 times weekly. After another 4 weeks, increase to 5 to 6 times weekly. Eventually, many people use retinoids nightly. This gradual progression minimizes irritation and maximizes adaptation. If you experience severe irritation, excessive peeling, or significant discomfort at any point, reduce back to a lower frequency. There's no rush. Building retinoid tolerance over several months is perfectly acceptable. Consistency matters far more than speed. Someone using retinol 2 to 3 times weekly for years will see better results than someone who uses it daily for 2 months then stops. Results from retinoid use appear gradually but are remarkable. After 4 weeks, you might notice smoother texture and reduced comedones. After 8 weeks, reduced acne and early signs of improved skin tone. After 12 weeks, significant acne improvement, smoother texture, and visibly improved skin. After 6 months, improved fine lines, more even skin tone, and dramatically clearer skin. After 1 to 2 years, comprehensive skin improvement including acne prevention, minimal fine lines, even skin tone, and visibly healthier, more resilient skin. Prescription retinoids like tretinoin work faster than over-the-counter retinol. Starting tretinoin at 0.025% and increasing gradually can show acne improvement within 6 to 8 weeks rather than 12 weeks. However, prescription retinoids cause more significant initial irritation, making the starting process more challenging. Many dermatologists recommend beginning with over-the-counter retinol to build tolerance, then switching to prescription retinoids if additional strength is needed. Retinoids are teratogenic, meaning they can cause birth defects if used during pregnancy. Women of childbearing age should use reliable contraception when using retinoids and should discontinue use if planning pregnancy or if pregnancy is suspected. Men can use retinoids without this concern. Common mistakes with retinoids include starting with too high a concentration, using them too frequently initially, applying to damp skin, using them with too many other actives, or discontinuing them during the retinization phase. Starting right requires patience and conservative progression. The reward for proper retinoid use is clear, youthful, healthy skin that continues improving even after years of use. Guide 7. Hormonal acne in women, causes, recognition, and comprehensive medical management. Hormonal acne is a distinct type of acne that affects many women and some men, following predictable patterns related to hormonal fluctuations. Understanding hormonal acne's unique characteristics and treatment approaches is essential for women struggling with acne that doesn't respond adequately to standard topical treatments. Hormonal acne typically appears as deep, cystic lesions, often concentrated around the jawline, chin, and lower face. These lesions are painful, tender to the touch, and located deep within the skin rather than on the surface. They're often described as having no head, meaning they don't develop the white or yellow center that surface pimples have. They can persist for weeks or even months without fully resolving. Unlike typical acne that might be spread across the face, hormonal acne often appears in the same locations repeatedly. The hormonal pattern of acne is highly telling. Many women notice breakouts occur in a predictable pattern related to their menstrual cycle. Breakouts might appear 3 to 5 days before menstruation begins, resolve during menstruation, then reappear in the luteal phase, after ovulation. This cyclical pattern is a clear indicator of hormonal involvement. Some women break out only during specific phases of their cycle, while others experience breakouts throughout the cycle with worsening at predictable times. Hormonal acne results from heightened skin sensitivity to androgens, particularly testosterone and DHT, dihydrotestosterone. These male hormones stimulate sebaceous glands to produce more sebum, even in the presence of normal hormone levels. Additionally, androgens promote follicular hyperkeratinization and may increase colonization of acne-causing bacteria. Women's testosterone levels fluctuate with their menstrual cycle, with higher levels during the luteal phase, explaining the predictable timing of hormonal acne breakouts. Recognizing hormonal acne requires tracking your breakouts. Keep a calendar marking breakout dates and your menstrual cycle dates for 2 to 3 months. If breakouts cluster around specific menstrual cycle phases, hormonal acne is likely. Polycystic ovary syndrome, PCOS, a condition affecting ovulation and hormone regulation, often causes severe hormonal acne. Women with PCOS typically have elevated androgen levels and irregular menstrual cycles. Topical acne treatments alone are often insufficient for hormonal acne. While they help manage symptoms, they don't address the underlying hormonal cause. Therefore, treating hormonal acne often requires systemic, oral, medications that regulate hormones or reduce skin sensitivity to hormones. Hormonal contraceptives are the first-line treatment for hormonal acne in women who desire birth control. The hormones in birth control pills suppress ovulation and, importantly for acne, reduce circulating androgen levels. Specifically, oral contraceptives increase sex hormone-binding globulin, SHBG, a protein that binds androgens and makes them unavailable to skin cells. The result is reduced sebum production and decreased follicular keratinization. Not all birth control pills are equally effective for acne. Combination pills containing estrogen and progestin are effective. However, some progestins have androgenic properties, meaning they act similarly to testosterone, and can worsen acne. Progestins with lower or no androgenic activity include norgestimate, desogestrel, and drospirenone. Birth control pills specifically approved for acne treatment by the FDA include orthotricycline, norgestimate, estrostep, norethindrone, yaz, drospirenone, and bayaz, drospirenone with additional vitamins. These pills typically show acne improvement after 3 to 4 months of use, with maximum improvement by 6 months. Starting a new birth control pill doesn't immediately improve acne. Acne often temporarily worsens in the first 1 to 2 months as your body adjusts to new hormone levels. This temporary worsening isn't a sign the pill won't work, it's normal. Stick with your chosen pill for at least 3 months before concluding it isn't working. If after 3 months acne hasn't improved, discuss switching to a different progestin or a different pill formulation with your gynecologist or dermatologist. Spironolactone is an alternative or complementary treatment for hormonal acne. This medication is a potassium-sparing diuretic that also acts as an androgen receptor antagonist, blocking androgens from affecting skin cells. Spironolactone is typically used at doses of 50 to 100 mg daily for acne treatment. It's often prescribed in combination with birth control pills for additional effectiveness. Spironolactone requires careful monitoring. Potential side effects include dizziness, lightheadedness, menstrual irregularities, and breast tenderness. More serious but rare
Cái này gì nó hay tí xíu ha.
Học dần dài với các bạn ngứa chị. Ở đây có nhiều vải nó đầy, nó lan ra. Sau nó cứng. Có gì xíu nữa ha.
some experimentation, patience, and willingness to adjust based on results. Most acne responds to consistent, appropriate treatment. Your clear skin is achievable with the right approach for you specifically. The ultimate lesson: acne is treatable. Whether your path involves topical treatments, professional treatments, hormonal interventions, or isotretinoin, solutions exist for your specific acne. Finding the right approach for your individual situation, maintaining patience and consistency, and persisting through initial difficulties leads to clear, healthy skin. Your acne journey is unique, but clear skin is absolutely achievable. #20 Expert Level Skin Care and Acne Treatment Guides, Part 3. Each guide, 10 to 15 minutes reading time. Guide 31, Acne Scar Treatments, Comprehensive Guide to All Scar Types and Advanced Therapy Options. Acne scars represent permanent reminders of severe acne, but modern dermatology offers numerous treatment options that can significantly improve scarring. Understanding different scar types, appropriate treatments, realistic outcomes, and combination approaches enables you to effectively address post-acne scarring. Acne scars exist in 3 primary morphologies, each requiring different treatment approaches. Ice pick scars are deep, narrow indentations resembling puncture wounds from an ice pick. These scars have sharp edges and typically measure 1 to 4 mm in diameter but penetrate deeply into the dermis. Ice pick scars are difficult to treat because their narrow base makes many standard treatments ineffective. Boxcar scars are wider depressions with relatively flat bottoms and sharp, vertical edges. These scars typically measure 4 to 6 mm or larger in diameter. Boxcar scars appear similar to chickenpox scars. Rolling scars are shallow depressions with sloping, rounded edges creating a wave-like appearance across the skin. Rolling scars often appear worse when skin is stretched due to their tethered nature. Understanding scar depth and type guides treatment selection. Shallow scars are often more responsive to surface treatments, while deep scars require deeper penetrating treatments. Mixed scar types within the same individual require combination approaches. Prevention remains the gold standard scar treatment. Avoiding picking, squeezing, or extracting acne prevents scarring. Treating acne aggressively to minimize deep inflammation prevents scarring. For anyone prone to severe acne, considering isotretinoin to prevent scarring is appropriate if acne is severe enough to cause scarring risk. For existing scars, numerous treatments provide varying degrees of improvement. Topical treatments are largely ineffective for true scarring, as scarring involves structural collagen loss that topical products cannot reverse. However, treating associated hyperpigmentation with topical treatments makes scars less noticeable. Subcision is a minor surgical procedure particularly effective for rolling and tethered scars. A needle or small scalpel is inserted under the scar, severing fibrous tissue anchoring the scar to deeper structures. This allows the scar to elevate as new collagen forms underneath. Subcision often requires multiple treatments performed weeks apart. Results develop over months as new collagen remodels. Subcision combined with other treatments, fillers, microneedling, often provides better results than subcision alone. Microneedling creates controlled microinjuries triggering collagen production and remodeling. The skin's healing response generates new collagen, improving scar appearance. Multiple treatments, typically 3 to 6 sessions spaced 4 to 6 weeks apart, provide progressive improvement. Microneedling works for all scar types but is particularly effective for rolling and moderate boxcar scars. Post-treatment appearance includes temporary redness and microcrusting. Recovery takes 3 to 5 days for most people. Microneedling is relatively affordable compared to laser treatments and is increasingly popular for scar treatment. Radiofrequency microneedling combines microneedling with radiofrequency energy for enhanced collagen stimulation. This provides better results than standard microneedling but with more significant post-treatment appearance changes and potential side effects. Laser resurfacing removes thin layers of skin, smoothing scars and promoting collagen remodeling. Fractional laser resurfacing treats portions of skin, leaving untreated bridges for faster healing and less downtime than full resurfacing. CO2 fractional lasers are highly effective for acne scars. Multiple treatments, typically 4 to 6 sessions spaced 4 to 6 weeks apart, provide progressive improvement. Post-treatment appearance includes significant redness lasting several weeks and potential for whitening, hypopigmentation. Cost is substantial, $500 to $1,500 per treatment, but results are often dramatic. 𝒂𝒏𝒄𝒊𝒏𝒈 fractional lasers are slightly less aggressive than CO2 lasers, with somewhat less downtime and slightly less dramatic results. For those seeking good results with less recovery time, 𝒂𝒏𝒄𝒊𝒏𝒈 is a reasonable option. Chemical peels remove skin layers through acid application. Superficial peels with glycolic or salicylic acid remove only the superficial layer and provide minimal scar improvement. Medium-depth peels with TCA, trichloroacetic acid, penetrate deeper, removing epidermis and superficial dermis, providing better scar improvement. Medium peels require 5 to 7 days of peeling and recovery. Deep peels with phenol or high-concentration TCA penetrate most deeply but require significant recovery time and carry higher complication risks. Deep peels are rarely used for acne scars specifically, being reserved for severe aging or other conditions. Dermal fillers inject material beneath scars to elevate depressed scars temporarily. Different fillers last different durations. Hyaluronic acid fillers typically last 6 to 12 months, while longer-lasting fillers, calcium hydroxylapatite, polyl-lactic acid, last 12 to 24 months. Filler results are immediate, making this attractive for short-term improvement. However, repeated treatments are necessary to maintain results. Fillers work particularly well for ice pick and boxcar scars. Platelet-rich plasma, PRP, therapy uses concentrated growth factors from your own blood to stimulate collagen production and healing. PRP is injected into scarred areas, promoting new collagen formation. Multiple treatments are typically needed. While PRP is popular, evidence for its efficacy in acne scar treatment is mixed, and it's more commonly used as a supplement to other treatments rather than as monotherapy. Combination approaches yield best results for acne scarring. A typical combination might include subcision for tethered scars, followed by microneedling for collagen stimulation, combined with fractional laser for surface smoothing and additional collagen remodeling. This multimodal approach addresses different aspects of scarring simultaneously. Treatment planning requires professional expertise. Severe, extensive scarring warrants referral to specialized dermatologists experienced in scar revision. Your dermatologist can assess your specific scars and recommend appropriate treatments. Realistic expectations are essential. Most scars improve significantly, 50 to 75%, but are rarely completely eliminated. Severe, deep scarring might only achieve 30 to 40% improvement even with aggressive treatment. However, significant improvement is usually achievable and worthwhile. Timeline for scar improvement is measured in months and years, not weeks. After a laser treatment providing immediate dramatic improvement, additional improvement occurs over 3 to 6 months as collagen remodels. Multiple sequential treatments provide cumulative improvement over 6 to 12 months or longer. Cost is a consideration. Professional scar treatments are expensive, laser treatments $500 to $1,500 per session, multiple sessions required. Microneedling is more affordable at $200 to $400 per session. Fillers vary based on amount needed. Insurance typically doesn't cover cosmetic scar treatment. Discussing cost with your dermatologist and potentially planning treatment over time is reasonable. Home care between professional treatments supports improvement. Proper sun protection prevents hyperpigmentation that makes scars more noticeable. Hydration and appropriate skincare supports skin healing. Some evidence suggests that certain topical ingredients like retinoids and vitamin C might provide modest scar improvement through collagen support, though these effects are minor compared to professional treatments. Scar appearance often improves naturally over years. Post-inflammatory changes gradually fade. Scars that seem severe initially might improve significantly over 12 to 24 months even without treatment, though active treatment accelerates improvement. Guide 32: Environmental and occupational factors influencing acne. Acne development isn't purely internal. Environmental and occupational factors significantly contribute to breakouts. Understanding these external factors allows you to modify your environment and workplace practices to support acne resistant to standard topical treatments, particularly if inflammatory and deep, often reflects hormonal causes. Women with other hormonal symptoms, irregular periods, excessive hair growth, hair loss, fertility issues, should definitely pursue hormonal evaluation. Primary hormone involved in acne is androgen, particularly testosterone and DHT, dihydrotestosterone. However, most women with hormonal acne have normal total testosterone levels but exhibit heightened skin sensitivity to androgens. This explains why some women with normal hormones still have significant hormonal acne. It's about skin sensitivity, not absolute hormone levels. Relevant hormonal tests for acne evaluation include total testosterone, free testosterone, calculated or direct measurement, DHT, dihydrotestosterone, DHAS, dehydroepiandrosterone sulfate, LH, luteinizing hormone, FSH, follicle-stimulating hormone, and androstenedione. These tests assess androgen status and ovulatory function. Additionally, tests for other hormones affecting acne include estradiol, progesterone, tested in luteal phase for ovulation confirmation, cortisol, for stress-related endocrine effects, and thyroid function, TSH, free T4, may be relevant. Ovulatory dysfunction, present in conditions like PCOS, contributes to hormonal acne. PCOS involves elevated androgen production, irregular ovulation, and insulin resistance. Women with PCOS typically have irregular periods, acne, hirsutism, excessive hair growth, androgenetic alopecia, pattern hair loss, and often obesity. Testing for PCOS is appropriate for women with these symptoms. PCOS diagnosis requires ovulatory dysfunction, irregular periods, plus hyperandrogenism, elevated androgens or clinical signs, and/or polycystic ovarian appearance on ultrasound. Baseline hormonal testing during the follicular phase, first 7 days of menstrual cycle, is standard because hormone levels are more stable and baseline during this phase. FSH and LH are assessed during the follicular phase. Progesterone is tested during the luteal phase, typically 7 to 8 days after ovulation, to confirm ovulation occurred. Testing hormone levels at the wrong cycle phase produces misleading results. Understanding test results requires expert interpretation because normal ranges vary widely, and what's normal for general population might indicate androgen excess relative to individual baseline. A testosterone of 50 ing/dL is normal for most women but might represent significant elevation for a particular individual. Free testosterone is often more clinically relevant than total testosterone because it represents the active hormone, though measuring free testosterone is technically challenging and prone to error. Elevated DHAS, particularly if greater than 350 μg/dL, suggests adrenal androgen excess and warrants further adrenal evaluation. Elevated androstenedione suggests adrenal or ovarian androgen production. Elevated LH with normal or low FSH suggests ovulatory dysfunction characteristic of PCOS. If hormonal testing reveals significant androgen excess, additional testing might assess the source. Adrenal tumors or ovarian tumors very rarely cause acne but can cause very severe hyperandrogenism. Evaluating clinical presentation helps distinguish adrenal from ovarian sources. ACTH stimulation testing can differentiate adrenal from ovarian androgen excess if warranted. Interpreting results in clinical context is essential. You might have borderline elevated testosterone with classic hormonal acne, jawline breakouts, cyclical pattern, making hormonal treatment appropriate despite normal lab values. Conversely, you might have elevated testosterone labs without significant acne, making hormonal treatment unnecessary. Clinical presentation guides treatment more than isolated lab values. When to pursue hormonal evaluation: irregular or absent menstrual periods, acne with cyclical menstrual pattern, acne onset in adulthood, acne concentrated on jawline and lower face, acne resistant to standard treatments, signs of hyperandrogenism, hirsutism, hair loss, male pattern baldness, family history of PCOS or hormonal disorders, concerns about fertility. Other reasons to evaluate hormonal status. Additionally, pursuing evaluation before starting hormonal treatments gives baseline data to assess treatment effectiveness. Working with appropriate clinicians, gynecologists are ideal for hormonal evaluation in women, though some dermatologists also perform this evaluation. Reproductive endocrinologists specialize in hormonal disorders and are appropriate referrals for complex cases or PCOS evaluation. Family medicine physicians can perform initial evaluation. Choosing a clinician experienced in hormonal acne and PCOS improves evaluation quality. After hormonal evaluation, appropriate treatment depends on findings. If PCOS is confirmed, treatment includes hormonal contraceptives for acne and period regulation, spironolactone, antiandrogen, metformin for insulin resistance, and lifestyle modification. If adrenal androgen excess is identified, dexamethasone might be considered. If results are normal despite hormonal acne pattern, empirical hormonal treatment, oral contraceptive or spironolactone, remains appropriate despite normal labs. Timeline for hormonal treatment effectiveness is months, not weeks. Hormonal treatments typically require 3 to 6 months to show acne improvement, with maximal improvement often occurring after 6 to 12 months. Patience is necessary. Discontinuing hormonal treatment after 2 to 3 months before full benefits appear is a common mistake. Reassessment after hormonal treatment initiation is valuable. Repeating key hormonal tests, particularly free and total testosterone, after several months on hormonal treatment confirms that the treatment is achieving hormonal effects. If testosterone hasn't decreased despite hormonal treatment, investigating why, medication noncompliance, inadequate dosing, ineffective treatment choice, is appropriate. Guide 38, Dietary Supplements for Acne, Evidence-Based Review of Oral Supplements. Numerous dietary supplements are marketed for acne with varying levels of evidence. Understanding which supplements have evidence, realistic expectations for supplementation, and appropriate dosing guides inform decisions about supplementation. Zinc supplementation has evidence for acne improvement, particularly in individuals with zinc deficiency. Zinc supports immune function, wound healing, and inflammation reduction, all relevant to acne. Studies show that oral zinc at 30 to 50 mg daily improves acne moderately. However, excessive zinc supplementation, above 150 mg daily long-term, causes nausea and interferes with copper absorption. Typical zinc supplementation is 25 to 30 mg daily. Zinc is more effective for those with demonstrated zinc deficiency, though some people without deficiency also benefit. Blood zinc levels can be tested to assess zinc status, though zinc testing is not widely available. Vitamin D supplementation shows promise for acne. Vitamin D has immune and anti-inflammatory effects relevant to acne. Low vitamin D levels correlate with worse acne. Vitamin D supplementation at 1000 to 400 IU daily might improve acne, particularly in those with low baseline levels. However, evidence is mixed, and benefits are modest. Vitamin D supplementation is generally safe and supports overall health beyond acne, making it reasonable to consider. B vitamins, particularly B5, pantothenic acid, are promoted for acne. Pantothenic acid is marketed at very high doses, 10 grams daily, claimed to reduce sebum production. While some small studies suggest benefit, evidence is weak. High-dose pantothenic acid causes diarrhea frequently and benefits aren't reliably demonstrated. Supplementation is not recommended without stronger evidence. Omega-3 fatty acids, fish oil supplementation, support anti-inflammatory effects and improve acne in some individuals. Omega-3s reduce systemic inflammation and support skin health. Typical supplementation is 1 to 2 grams daily of